Hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and thank you for listening to our podcast. It's called Australian Anaesthesia, and it's where we talk about all things relevant to anaesthesia in Australia, and in this case, anaesthesia worldwide. In this episode, I'm chatting with Dr David Borshoff, an anaesthetist from Perth in Western Australia and author of the Anaesthetic Crisis Manual. I've already chatted with Dr Borshoff on an earlier episode of this podcast about how the Anaesthetic Crisis Manual came about. So in this episode, we are diving into the latest edition, that is the 4th edition, which came out late last year. What I do like about this edition is the crisis prevention section, which is new compared to previous editions. Dr Borshoff does mention it briefly during our conversation, but it really came in useful for me in theatre a while ago. The trainee I was with wondered if our fit and well ASA1 patient could have Wolff-Parkinson-White. They thought on the monitor that the PR interval was shortened and that there was a delta wave. So we printed out a rhythm strip and lo and behold, it was there on paper as well as having been on the monitor. As the trainee was preparing for their final exam, we then embarked on a useful discussion on what would you do if this patient suddenly developed a tachycardia. We talked through the process, we scratched our brains on the particular antiarrhythmic that can be used. It's procaine amide, by the way. Our anaesthetic nurse was also paying attention to this discussion, and we confirmed that procaine amide wasn't kept in our theatre complex and we'd have to request it from pharmacy if we wanted it. All in all, a very useful conversation, and I was glad to have a copy of the manual with me in theatre so I could look it up. Dr Borshoff, as you'll hear, is passionate about this manual, so passionate that he started a publishing company in order to get the manual published. But it's more than being about the book. He's passionate about supporting and developing the culture of using cognitive aids because none of us are infallible 100% of the time. The ASA is also supportive of this concept. Both Dr Borshoff and the ASA are so supportive of this that we have made the Crisis Manual free for advanced trainees and discounted for ASA members. We do go through the details of that offer in this podcast, and you do have to be an ASA member to claim it. Now, if you like hearing interesting clinical vignettes, especially airway ones, then I suggest tuning in to the end of the episode where Dr Borshoff describes his experience of performing an emergency front of neck access. Always enlightening. I always learn something when I hear about people's direct experience of this because, touch wood, it has not happened to me. But for now, let's get into finding out more about the 4th edition of the Anaesthetic Crisis Manual. Thanks for giving up some time this morning.
No problem.
We're here to talk about the Crisis Manual. It's been 15 years, I read in the introduction. That is incredible.
Time flies.
And what number edition is this?
So this is effectively the 4th edition, Susie. The 1st edition was produced by Cambridge University Press, but they didn't produce it in the format that I was hoping. And once you sign a contract with one of the big publishing companies, you sign away some of the control. So I got my copyright back. After about 12 months, they just offered it to me. They detected that they had a disgruntled, painful anesthesiologist on the end of the line and that life was going to be easier for them if they just gave him a copyright back.
That's good they honoured that.
Yeah, they were nice people and they were good to work with, but they produced a little sort of aid memoir rather than the manual concept that I had envisaged. So once I got that copyright back, that's when we set up Lewin Press, our own online publishing house, and with the graphic designer that I was working with, we produced our own version, and that was in 2013. And then in 2017, we updated that, and that became version 3, even though it says version 2 because it was really Lewin Press version 2, but it was essentially the 3rd edition. So we've labelled this the 4th, and I think that's appropriate.
And there's some big changes in this edition in terms of, well, there's 2 editions. First of all, there's the US one and then the international one.
Yeah.
Going through them, I did compare them side to side. Thank you for sending them through. But they looked similar to me. They've got exactly the same number of pages. And I picked up small things like the spelling of manoeuvre.
Yes.
Those little things. And I thought, oh, How is the term anaesthetist in here and you've stuck with anesthesiologist throughout?
Well, I did that because of the European Society and the fact that it's the most common term worldwide for what we do. So it's pragmatic. The majority of people across the world, as you know, are anesthesiologists. The only reason we produced a North American edition is the practical side of things. I wanted it to look like that it was produced in their own backyard so that they felt more comfortable using it. The page numbers and the content, the protocols are all the same. There are subtle little differences. And, I had a lovely guy, Jeff Lighthall at Stanford, really smart, very much a supporter of the manual concept, and he'd been through it, and we just had to make sure that he was comfortable with it. So he did some of the edits, gave me some really excellent feedback. In the end, we were able to find common ground, because when he first gave me the feedback, I was just a little bit crestfallen because I thought I was close to finishing. And he actually brought up some really good points, particularly with the airway management, because that's always controversial. So after a lot of toing and froing, I sort of went back to the drawing board and I had to throw some things out and start again. And in the end, there's no perfect solution, but in the end, I incorporated some of the DAS guidelines.
Difficult Airway Society.
And the Vortex. And, I'm not hesitant to say that I really love Nick Crime's Vortex concept. It appeals to me. I like the graphics. I like the simplicity of it. And I think it's been a very effective tool. And I know that a lot of people have engaged with it. And that's one of the reasons why I use it in the manual. But I'm also aware that there are different airway groups, and I had to try and consider how we incorporate both.
I'm doing an analysis at the moment with WebAirs on front of neck access, and I noticed there were slight differences in terms of the technique for cricothyroidotomy between the US and the international edition.
Yeah, and that's a hard one. And of course, I come from Western Australia, and Andy Hurd, I was there at the beginning with Andy, who was pioneering this sort of stuff in terms of teaching us. And so I feel a degree of loyalty to Andy and what he achieved with his airway workshops. And I've come to the conclusion that a lot of the rest of the world is moving more towards the surgical cricothyroidotomy. I've maintained the cannula cricothyroidotomy as well, because I know that here in Australia, at least, we do the workshops, we learn both techniques. And I think it's important that rather than pick one and stick with it, both of those are at your fingertips and that you're familiar with them.
Yeah, and that's really clear. I just taught EMST on the weekend.
Oh, well done.
Oh, thank you. I've been teaching EMST for way too long, perhaps, but back in the day when we used to do surgical cricothyroidotomies on live animal models, so I've definitely done more of my practice and training using the surgical technique. So it was good. I really liked how that was presented in both versions of the manual. That was really clear.
Oh, that's good, Susie, because that caused me the most concern and angst in trying to do that relatively simply, but to convey the essentials. And there are even subtle differences. The way we are taught here, the long vertical incision, and then you can use the scalpel bougie technique to get through the trachea. But in the US, they stick the scalpel in and cut across to one side, cut across the other side, stick their finger in. They're really right in there physically with it. So that's a subtle difference. I tried to accommodate all of those.
Yeah, there's so many ways to do it. I don't think we've landed on an international single best practice, and I don't think we ever will.
I think we've got reasonably close, but I'm not sure we're going to get much further than where we're at the moment.
Yeah, I'm used to the scalpel bougie technique, but the surgeons, interestingly, they're teaching scalpel spreaders bougie. Assuming you have spreaders, but we don't have spreaders in our kits in theatre.
No, we don't. Yeah.
You brought up simplicity, and that is one thing I'm always really impressed at when I look at the manual, because I don't know if you've heard that saying, complexity is easy, simplicity is hard. It takes a lot of work to whittle it down to the key points, and yet you manage to do it again and again and again with each scenario.
I'm glad you've brought that up, because I was surprised how much work was involved this time round for me to do this, because of exactly that reason. When I say how much work, I think probably for the last 9 months, it was a bit like studying for the fellowship in terms of time commitment.
I believe that.
Each weekend, I'd be up at my desk at 6:30 reading papers.
You must be full bottle with knowledge right now, like post-fellowship exam level.
Absolutely. Briefly, but come and talk to me in 3 or 4 months and I'm sure I'll be trying to recall things and, anyway. But yeah, it was good for that. It keeps you interested in your profession and it keeps you at the pointy end. But yeah, getting the gist and the information down to just one line, you'll see in the manual, I tried to keep each directive as one line, and that's very hard to do.
I believe that. I'm thinking behind every line, there's papers, there's studies, there's this desire to go, oh, there's this caveat, there's this particular
correct
example of where it might differ, but I really appreciate how you've distilled that right down. I do appreciate the amount of work that would have taken.
That's kind of you. But as I said before, none of this is perfect, particularly given the linear type progression of the directives. That's the sort of style that I've used for the manual because I've wanted to remove as many decisions from the user as possible. One of the issues that I had with the old algorithms is that there was a lot of, if it's this, do this, if it's that, do that. When you're cognitively loaded, you want to be making as few decisions as possible so that you can stick to the big stuff. And because of that, it's not always perfect, but, it's a pretty acceptable position that I came to in the end.
It's like coming up with a checklist.
Yes.
For every crisis situation, isn't it? And that's incredibly difficult.
It is. And because of the nuance and the subtleties and the slight changes, and sometimes there's two things going on. And I think that the thing that made the manual work well the first time we brought it out was having a prevention section, sort of trying to convey that most of the time go off before a crisis develops. And if you're all over the reasons for core parameters changing, you might be buying yourself some time before a full-on tightly coupled situation.
Checklist appeals to me because unlike an algorithm, whereas if you've done something on a checklist because it happened to be in an algorithm on another pathway, you just go tick and you move to the next one. And at least it gives you that sense of accomplishment.
And also removes some anxiety when you know you've got things covered.
You mentioned in the introduction that you've partnered with MSF and the International Committee of the Red Cross. Tell me about that.
That was rather embarrassing how long it's taken, but we've got there in the end. So I was contacted by Amin Lamrus, who works for the MSF, and he was impressed with the appeal, the aesthetic appeal and the simplicity of the manual, and realised that it would be a great asset for their workforce, obviously, and given the situations that they're in, was keen to do a limited resource or low resource setting edition. So I spent a week or two with him last year going through the protocols because I was going to produce 2 editions, a limited resource edition and update the regular manual. So he had got together with the Red Cross and they had a team who went through the manual with a fine-tooth comb to look at what they would change. So I had those protocols at hand, but once I started updating the manual and I was going to try and do both at the same time, I realised that there was significant overlap of the 2 manuals, and I thought it would be good for those privileged people working in well-resourced hospitals to also be aware of issues when you don't have those resources. So after discussion with Amin, I said, look, I just think we should make it one manual and bring them on as collaborators. And so that's what we did. And so we added protocols, unexploded ordnance.
I saw them about unexploded ordnance.
Yeah, oxygen failure, power failures, which, we can all have in major hospitals. But when your whole operating theatres are dependent on generators in low resource settings, it brings home how you have to think and the contingencies and how you have to prepare. And I just thought that was helpful for everybody practicing anaesthesia.
For sure. There was that recent incident, wasn't it, at a Sydney hospital where someone sabotaged the gas supply?
It's not unheard of in our urban centres.
Yeah, exactly. I like also that you dedicate this one to the memory of Irma Brayley, who we talked about in our last podcast. That is going to be one of my favourite podcasts because of that story that just unfolded.
Bless Irma. Yeah, she was a lovely lady.
I want to go back actually to around that time that she was in your life, that you were coming up with a concept and you were moving into the second edition, you were wresting your IP, your copyright back from Cambridge, and you set up Lewin Press. It is going back a while, but what went through your mind in terms of setting that up? Can you recall that time?
Yeah, I can. I think the internet was in full swing by then, and it occurred to me that this was my baby and I was a bit of a control freak, and the only way to produce what I thought was required was to do it myself. So in a sense, it was a self-publishing concept, but there are a lot of publishing houses or places to go that, in my opinion, weren't commensurate with the product that I was wanting. In the early days, when I actually had just come up with the concept of cards for crisis control, was the precursor to the ACM. I had been working with this graphic designer in Perth, and they had done a lot of the design for those things with me. And so then I brought them on board and set up an online company. And Lee Turner, who's very savvy with setting up websites and all the business back end, which I couldn't have done without him. So I was in theatre one day and I called up the accountant and said, listen, I want to set up a company. And she said, well, I need a name and before we get you the ABN. And I was working with this anaesthetic technician. And I said, people, I need a name for a publishing house. And so we just had a brainstorming session and she was very good. She said, it needs to be something local. And she came up with Lewin, which is strongly associated with the southwest of Australia. And we have this magnificent three-master sailing boat that they take high school kids out on called the Lewin. And so we used that as our little logo and we created the company and we got the ball rolling. And then once we had an online presence and then word of mouth, it gathered momentum. So that's how Lewin Press came about.
Right back at the start, you said that you were working with a graphic design team to make those cards.
Yes.
How did you go around finding the right graphic design team?
Look, it's interesting. I just wanted to make a comment about those cards in simulation. You know, as I think I mentioned in the earlier podcast that we did a long time ago, after the Irma crisis, I took myself off to the simulator about 3 times over the 18 months. And I remember returning on one of the flights and I was stymied in one of the simulations and I remember feeling a bit embarrassed and reflecting and beating myself up.
We've all been there.
The issue was that the tube was blocked and I had suctioned the tube, and in the simulation thing I thought that had clarified that the tube was clear, but I hadn't suctioned far enough and it was kinked and the CO2 was going off. And I remember in the simulation standing there looking at the rest of the team saying, anyone got any ideas? I was reflecting on that, and they had said, look, don't tell anyone about the scenarios because it spoils it for them. And I thought, actually, I'm going to tell everyone about the scenarios.
So much so I'll start a press company.
Because they need to be thinking about these things and they need to be rehearsing them. And even when you get in a simulation, you still don't quite know what's going to happen. So I sort of took the opposite tack. And I understand why they did that, of course, and that's how I came up with the concept of cards initially. And I got hold of that graphic designer because I worked with a plastic surgeon at the time and he had been involved with the Rafiki medical missions to Tanzania, and they had used this graphic design company for some of their stuff. And he said, oh, you should speak to so-and-so. And it was a great recommendation. So Graphic Source has been a great support over the last 15 years.
I think that's often the hard part with any of these sorts of things is that first step. And then once you get a bit of momentum, look at where you were 15 years ago and now you've got international NGOs, you've got overseas anaesthesia societies, you've got 2 editions coming out.
And I wanted to market it as a sort of premium product, right? So in the early days, I had my kids packing the manual orders into these little boxes that graphic design had created, and we had stickers on the front. But God, I tired of that really quickly. It was a huge relief when eventually we got a pick, pack and post company on board, and the orders now go straight through to their computers. It's more of a hands-off approach, but yeah.
Well, you must be creating at scale if you can now outsource some of the work. That's great. Congratulations on that.
Thank you.
Speaking of packing things and sending them out, I wanted to discuss the offer that we have for ASA members because you've been a great supporter of the ASA through the Crisis Manual. So thank you for that.
It's okay.
How I see it is that there's 2 different offers. There's ones for trainees and then there's one for our ordinary ASA members.
That's correct.
Actually, before we go into the details of the offer, there's 3 versions of the manual.
There are.
There's the premium one that sells for $90, the standard edition that sells for $75, and then there's the e-manual, a fully digital version for $60. Did you want to tell us about some of the differences between those versions?
So one of the issues that we constantly face on the business side of things is trying to stay viable, because postage from Australia when you're a small business is actually very significant. And now in the US, there's some $5 fee for each item in terms of their tariff introduction. And just to give you an example, sometimes the postage is up around the $28 or $30 mark. And if you're trying to sell a manual for $55, which was where we were a while back, I was concerned for the viability because, I'm proud of the company, but essentially it operates as a not-for-profit. Not officially, but it makes enough money through its sales for me not to have to put any money into the company. And it covers the expense of graphic source and Lee managing the business, and that's it. So when I was looking at the postage costs, I thought that we had to do something in terms of keeping the cost down. So the premium edition is on synthetic paper, which is water resistant, tear resistant, and it's the sort of manual that I would strongly suggest for hospital departments, when they're sitting on anaesthetic machines or in the operating theatre environment where there might be occasional spillage or, contamination. It's the expense of that paper that separates it from the standard edition, which is just on normal, recycled, good quality paper. But that's not water resistant or non-tearable. And so I market that as a standard edition for people that might want to carry it around in their briefcase or carry it with them and rehearse from it as a personal copy. And then the e-manual is just the digital interactive PDF digital edition that people can either download separately, or if they purchase one of the other two manuals, they get an automatic download of that e-manual. So when I was trying to make that call, I looked at what Stanford were doing with their emergency manual, because I think there's been cross-fertilization of ideas between us, and I see that they're producing a copy for about $120 US with the cut tabs. And we started out with cut-in tabs on the pages, but that ended up being prohibitively expensive. So if you think about it, at 120 US, that's nearly 200 Australian dollars. So they've got that edition, and then they've got a similar edition for about $100 without the tabs. And then they produce a pocket version for coat pockets, but we don't wear coats. So I tried to simplify it with just the three, the e-book and the standard and premium edition.
So people can get the manual for free, and that's the trainees of the ASA. So the offer for trainees is that if they're a basic trainee member and then they continue to become an advanced trainee member, pay up their renewal for their advanced trainee membership, then they will get a free copy of the standard edition.
Yeah, it's of the standard edition.
Lovely. And all they need to do for that is stay on and be a member and pay up their advanced trainee membership fees.
That's a great thing, because it helps embed into the culture the emergency manual cognitive aid concept. If I had to state the one disappointment from this whole experience that I've had, is that embracing the concept of emergency manuals and cognitive aids hasn't been as quick or as thorough or as widespread as I would have liked. There's lots of personal feedback. People love the manuals, but I had always seen it as being attached to the anaesthetic machine, there in view to remind people on a daily basis that stuff happens, and that if you haven't done CPR for a while, you might just want to flick through the manual and remind yourself of what it's all about and when you need to give the adrenaline or the amiodarone or how many joules, etc. That being present and being aesthetically pleasing to my eye, at least, that there would be more engagement. And I know that there was an initial surge, but there was also removal of manuals from machines and operating theatres.
Probably infection control had something to do with that.
Well, I don't know if infection control had as much to do with it as enthusiastic people that wanted their own copy.
Okay.
And I'm glad you mentioned infection control, because we've got these plastic covers on the front and back so they can be wiped. What I noticed on the first manual was that we didn't have those plastic covers, and with the chemicals in the cleaning wipes, that it's faded. We've produced also these manual holders that you can buy online as well. They actually sit through the spine and they have a ring at the top, and we don't see that many of those being sold, but that's the concept. Have it attached by a chain to the machine. And I think this is something that Stanford's done well because they're an academic department. They've formalised the attachment position on their anaesthetic machines. And I think we've got a way to go in that.
I just wanted to talk about the second offer, which is for ASA members. So any ASA member can purchase any edition, I take it, be it premium, standard or the digital version. And if they do so, they'll get a 20% discount.
Yep.
And they just need to email the ASA team on membership@asa.org.au in order to get the discount code before they go onto the Lewin Press website to complete the purchase.
Yep, that sounds right to me.
Excellent. I wanted to see, is there anything else that you wanted to mention about becoming a publisher or the crisis manuals or how we deal with crises?
Look, we could talk all day on this sort of stuff, but the first thing I would say is that, I have been involved with the ASA over the years, as you know.
Yes, you've made a great contribution. Thank you.
But I also wanted to thank the ASA because back in the time of Andrew Miller and Richard Gritzner, who actually got behind the concept, and they were big supporters. And I think that has been a great help to us in terms of establishing the manual as a reputable cognitive aid for crisis management. So, yeah, I've been the beneficiary of the ASA also. In terms of setting up a publishing company, there's a lot of work involved here and there's a lot of time. I think, as Amin Lumra said to me, the guy from the MSF, he could tell that it was a passion project. And I think if you've got something that you're passionate about, then you're prepared to do the work and you don't realise how many hours are ticking away while you're doing it. I think the aspect of publishing and getting involved in this that I would want to talk about with young anaesthetists in this country is that it helps maintain your love of the profession, and the curiosity of being a doctor is an important part of maintaining your engagement. We can all be very good anaesthetists, good technicians, and give a great anaesthetic. But if you do that year in, year out without maybe some associated activities that takes the brain in a slightly different direction, you might start to get a bit ground down by it, or maybe even a bit bored with your profession. And I think in all specialties, those people that can move outside the mainstream of it with some of these little side interests, no matter what it is, helps keep you engaged with what you originally started out to be, if you know what I mean.
I do. And on behalf of the ASA, anything that makes anaesthesia safer for patients and makes life easier for anaesthetists, I think we're always really happy to support. And I think this is a really clear and great example of that. And I love your words about, yes, I think to have a long, successful career, I do really encourage people like yourself to follow their passions, follow those creative projects, be curious.
And I think the word creative is a really important one because medicine is a pretty serious subject and we're taught pattern recognition and there's a lot of theory and rigidity in medicine. If you have a bit of a creative bent, being able to express that somehow, and even in a way that's connected with your profession, is a really nice combination.
Absolutely. Says she hosting the podcast.
Absolutely. A great example. And that's the point I was going to make. I just want to clarify that these cognitive aids, I want to put this disclaimer in, that in the early days there was some resistance to cognitive aids and there's ego and intellect involved in this, and there are a lot of doctors who felt that they shouldn't be looking at checklists, and the word checklist itself has a negative connotation for many people. But the crisis manual is there to support the clinical acumen and the decision making of the doctor. It's not the other way round. And studies have shown over and over again decreased anxiety in those teams that have cognitive aids when they're managing a crisis. And that's essentially, in my opinion, one of the greatest benefits of having something like the crisis manual handy in the operating theatre is not because you're going to reach for it first when you're managing the crisis. You're going to start managing the crisis, and then if you're maintaining your situational awareness, you're going to ask that someone gets the crisis manual to make sure that you haven't missed anything. And it's that whole concept of can I still bring this to the table? And part of the cognitive load is, what am I missing? Have I done everything? And if you've got something that you can just say, oh yeah, look, we've turned the theatre temperature up. Yeah, we've checked the calcium. That's good. It just makes for a happier, more relaxed anaesthetist, reduces their cognitive load, increases their situational awareness, and brings back that sense of control. I think that's the beauty of the cognitive aid. It's not that it manages the crisis for you, it just supports your training and experience in a really positive way.
Yeah, I hear in that when you mention ego, the counter of that is humility. And it's not just us. We work in a team.
Yes.
And we have team members who are busting their gut to help us. So helping them help us is also really valuable too.
And, there's no better way to make the point about the team and about creating the environment where people can speak up than when I was involved in the heat of the moment having to do front of neck access in a colleague's theatre. I was called in to help.
So you've done one in anger.
I have, and it was a very traumatic experience. And it was successful in the end.
Well done.
And I won't actually take you through all the hurdles that we had to cross to get there. But suffice to say that I was trying to do a scalpel bougie technique on this short-necked rugby player build patient whose airway had been lost. And when I was called in, it was already a long way down that dark tunnel. Right, so it wasn't like going through the steps nice and systematically. We were a long way down that tunnel, and I recognised quite soon that we had to do front of neck. So I actually developed fixation error. I'd gone through a few things, and I had got to the scalpel bougie technique. I did some things right. I made sure they called the surgeons back from the tea room because they were just putting the patient off to sleep. I made the call to do front of neck access. They were both very good decisions, but through a number of little holes in the Swiss cheese, I didn't get the right scalpel. I didn't even have time to put gloves on. Once I put the scalpel blade in without a handle, blood went everywhere. It became a very slippery, catastrophic mess. And so on my third attempt at trying to do the scalpel bougie technique, I had got a bit stuck on that technique. I should have moved on. There was a cast of 20 in the operating theatre at that stage. And the anaesthetic technician at the end of the bed, lovely guy, said, "Why don't you just do it properly, Doc?" And when I tell that story, when I'm presenting on this, people laugh. But he said exactly the right thing to me. It just knocked me out of my fixation area, and I thought, God, he's right. I need to just open this neck. So I did a vertical incision, separated the strap muscles, exposed the trachea, and just as I did that, the surgeon walked in, and I had sort of almost come to the end of my rope in terms of calmness, and I said to the surgeon, I need to just get in here. And he just got the scalpel, opened the trachea, and I just stuck the bougie down, tube over the top, and it was all good. But it is a fantastic example of how people feeling comfortable enough and part of the team to speak up and saved a patient's life.
Absolutely. Incredible.
It's a great story.
It is a great story. We always love a good story with a happy ending. Well done.
There was a bit of PTSD after that I had to navigate.
Oh, I'm sure.
But it was a great story.
All of these, I think any airway issue, when I think about the times when I've had fixation errors and things like that, particularly to do with airway management, you remember those for decades.
You do. What stays with you?
Yeah, it does. And thankfully they don't happen that often. Touch wood, it stays that way.
Yes.
Gee, well, look, it's been wonderful as always chatting with you. I always love catching up with you.
Yeah, it's been good, Susie. Yeah, nice to talk to you.
Thanks for your time today.
Absolute pleasure.
Well, I hope you enjoyed that conversation and perhaps might be inspired to purchase your own copy of the Crisis Manual. I certainly was after our conversation, and now you know the details of how to claim your discount as an ASA member. I do really appreciate David's words about having a passion project or creative outlet in your career. Obviously, as I say in the podcast, here I am making a podcast. I think of some of the other ideas that people have brought to the ASA, things like the Part Zero course. From what my predecessors have told me, the ASA started the Part Zero courses as we recognised that trainees were starting their career and could really benefit at that time with some tips on how to navigate their training and the transition to becoming registrars. Another example is the Real World Anesthesia course, a course for anaesthetists who are interested in working, volunteering in low-resource settings, austere environments, developing countries. That was started by some anaesthetists who then came to the ASA to see how we could support it. So if you have a passion project, and I know many of you out there do, then I do invite you to consider how the ASA might be able to help, and there are various ways. Moving on, some other podcasts which you might find interesting to listen to after this one is episode 25. That is where I talk about the history and the development of the Anaesthetic Crisis Manual with Dr David Borshoff. As I said during the podcast, this is one of my favourite episodes. I love how the story unfolded about Irma Brayley, and she's the woman who inspired him to develop the Anaesthetic Crisis Manual in the first place. Another episode is episode 78, which is about AMAX4, a truly heartbreaking story in this one. I chat with Dr. Ben McKenzie about the cognitive aid that he has developed called AMAX4, which prompts us to secure the airway within 4 minutes in someone who is experiencing anaphylaxis with marked bronchoconstriction. This was inspired by the tragic loss of his son and also involves another emergency front of neck access. I'm hoping you've listened to this podcast because you too see the value of cognitive aids in anaesthesia and in particular in a crisis. I'll share the email address and the links to the Lewin Press website in case you want to order your own crisis manual. I'm wondering also if you can do me a favour and share this episode with someone else who you think might benefit. They might benefit from knowing that there is a new edition of the Anaesthetic Crisis Manual. Maybe they're eligible to get it for free or at a discounted rate. I'm hoping to spread the word and really to make anaesthesia as safe as possible and to keep us working happy, healthy, long careers where we can feel confident managing crises. Till next time, I hope you and your patients stay safe and stay well out there.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists with many thanks to host and editor Dr Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.